dear leaders, dear supervisors, and dear colleagues. I would like to introduce my 6-month progress regarding my projects. So I've got 2 projects, and if I want to have one title for both projects, that would be the epidemiology and the management of hemodynamic instability in gastrointestinal bleeding. I am Mahmoud Obeidat. I am under the supervision of Balint Irush and Brigitte Teutsch, and our statistician Daniel Veresh. I would like to thank them for the huge contributions regarding these projects. So my vision is to improve care and the outcomes in hemodynamic instability in gastrointestinal bleeding, and maybe at the end come up with the guideline-based treatment for those patients. And my mission for that is to prove statistically the high prevalence of hemodynamic instability and the different in the variability in the different treatment methods. So as a message for everyone, our visions must be translated into actions. And I think I want to mention this quote, "Hope is not a strategy," and I think everyone is familiar with this quote. And I think we know who owns these words, the one and only Peter Hegyi. So now I would like to give a short overview of my 2 projects. The first one is looking at the prevalence of hemodynamic instability in GI bleeding, and the second one is looking at the management for those patients. So now I will talk in details about my first project, which is going to be a systematic review and meta-analysis. So as a background about this topic, I want to highlight 3 main points here. So the incidence of GI bleeding is 100 per 100,000 population annually, with a mortality rate up to 15%. And many studies showed that hemodynamic instability is significantly associated with mortality. And in one of those studies, they mentioned, like in non-variceal bleeding, 44 of the patients, and in variceal bleeding, 66 of the patients develop hemodynamic instability. So the aim is to know the exact prevalence of those patients. So our clinical question is the prevalence of hemodynamic instability or shock in gastrointestinal bleeding, and we've used the Coco-Pop framework for that. So our condition is hemodynamic instability or shock. The context is gastrointestinal bleeding, and the population adult patients more than 18 years. And we've done the systematic search in 3 main databases, the PubMed, Embase, and Cochrane, and we've got this search key, which contains 2 main concepts. The first part is basically the gastrointestinal bleeding with different synonyms, and the second part, basically the shock or hemodynamic instability. This is a selection flowchart of my project. We've started with 11,000 hits, and we've managed to downsize the articles into 220 that they were eligible for data extraction, with a substantial agreement between my co-investigators. So now I would like to introduce my results. I have 7 first plots like this. I would give an orientation how to look at the slides. So on the right side, you see the source of bleeding. So we've divided the articles based on the source of bleeding. And on the upper part of the plot, you can see the name of the articles, the event, those who developed shock or hemodynamic instability. And then the third column is the source of bleeding, in this case, GIB, which is gastrointestinal bleeding in general, when the articles didn't specify the source of bleeding exactly. And on the right side, you can see the prevalence and the 95 confidence interval. We've made the subgroup analysis based on those who developed hemodynamic instability and the other part on shock. And at the bottom, you can see the overall effect for different sources of bleeding. In general, in gastrointestinal bleeding, we've got 25% of those patients gonna develop shock or hemodynamic instability. Our second source is upper GI bleeding, again with the different sources, and with prevalence up to 20%. In non-variceal bleeding, as an overall effect, again 20%. And in variceal bleeding, since it's a more severe bleeding, we've got 25%. That means 1 in 4 patients in variceal bleeding gonna develop hemodynamic instability or shock. In peptic ulcer bleeding, 27%, and if you can see the results, I try to zoom in, and in lower GI bleeding, 27%, and in colonic divertical bleeding, it is around 12%, which means 1 in 10 patients of colonic divertical bleeding develop shock or hemodynamic instability. So what are our strengths and limitation here? The first strength that this is the first study to assess hemodynamic instability or shock in gastrointestinal bleeding. And we've got large number of articles, more than 200, with more than 6 million patients included in the study. And our limitations, that the definition of hemodynamic instability and shock is not exactly the same in the different studies. And in 1/3 of the studies, we lack those definitions as well. So as a conclusion, in gastrointestinal bleeding, we've got 1 in 5 patients. In non-variceal, we've got 1 in 5 again. In variceal bleeding, 1 in 4. And in colonic diverticular, 1 in 10 patients gonna develop shock or hemodynamic instability. So as a summary, as implications for the practice and the research, implication for the practice that to increase insight and awareness about hemodynamic instability and shock in gastrointestinal bleeding, and those patients need to be taken care of more carefully and monitored rigorously, and for prevention and screening as well. And implication for research, we have, I think, to standardize the definition of hemodynamic instability and shock for those patients worldwide. I would introduce my second project now, which is going to be an international survey looking at the management of hemodynamically unstable, non-variceal upper GI bleeders. As a background about this topic is almost exactly the same as the first project, but I would like to add here that there are gaps and uncertainties in the ESG guideline, the most recent update, that they clearly stated there are gaps how to manage those patients. They just mentioned that we should use crystalloid fluids, but they don't know the optimal rate of the fluid, for example. So the aim is to better understand the care, the assessment, and the management of those patients by doing an international survey and an online questionnaire for those doctors. So our hypothesis is that there is a significant heterogeneity between the different treatment methods, and we believe that it is based on the years of clinical experience for the doctors and the individual patient factors. And for that, we are building our questionnaire with a 3 main sections. The main section is basically demographics and clinical practice, and it's actually about the doctors who are going to participate in the questionnaire. We're going to include questions regarding the geographic region, whether they provide 24-hour gastroenterological care, interventional radiology, surgery in their clinics, and how many patients they have annually, hemodynamically unstable patients. In the second section, which is going to help actually our limitation in the first study about the definition and terminology of hemodynamic instability. So we want to know how those doctors define it actually. And the third and main section here is stepwise assessment and management for those patients. And this section is going to be further subdivided into 3 main sections: the pre-endoscopic assessment, endoscopic care, and post-endoscopic care. So this is a flow chart of the survey. So we've got the survey idea and the decision about the survey, and now we are building the questionnaire. We're trying to make a very high quality answers and as simple as possible to doctors to fill. And I would like to close my presentation with a quick overview of my 2 projects, and we planning to submit the projects in April and July of this year. So before I close my presentation, I want to end it with this quote: what we know is a drop and what we don't know is an ocean. And I would be happy to answer your questions. And thank you for your attention.
Thank you for your presentation. My question is related to your first project. Is there any other basic characteristic that would worth to make a subgroup analysis on?
Thank you for your question. Actually, we are still thinking about that. We are trying to make subgroup analysis or just include those articles who have the same definition of hemodynamic instability, for example. So we got more precise data.
You mentioned screening and prevention on your first project. What would be your suggestion for prevention the bleeding?
Thank you for your question. I've been thinking about that, and okay, so the aim of the study to know the prevalence of those patients, because those patients are at higher risk of mortality. And then what? We know the numbers. So what I meant by prevention and screening is, for example, those patients who are prescribed NSAIDs, for example, and NSAID can lead to ulcers. So they need to have prevention so we should prescribe proton pump inhibitors, for example, for those who are taking the drug. So we want to encourage the doctors more to give those drugs. For example, in variceal bleeding, as a primary prophylaxis, we should encourage, again, giving, for example, non-selective beta blockers or endoscopic band ligation. So this is the main of the prevention and screening before jumping into the mortality. So there's two main things to focus on, which is prevention and screening. And this is the main focus of the study, actually. Thank you for that. So
this is about your second project with the survey. I would like to assume that this inconsistency in protocols is not because of the ignorance of physicians. There has to be some kind of cause and effect relation or some kind of continuum wherein they decided to use that protocol. So in your survey, do you also plan to ask questions into how come you ended up with this protocol which is different than others? What led you to adopt one protocol over the other? Because this is the difficult thing about building a consensus between physicians, that they say, we can't, because this is how we always did and this is what we have to do. Do you plan any questions like this, maybe?
This is a good question, and as I mentioned in my hypothesis, it's not like the patients, they can't be treated the same. So there is individual patient factors, and there is also, it's based on the clinical experience of the doctors as well. So we can't just have one protocol to treat all patients with the same intervention. So we're gonna focus on hemodynamic instability, how they actually define it, and how they manage those patients in different cases, in different sources of bleeding. Do they, for example, do they send them to the ICU? Do they have more attention? Do they have interventional radiology more than others? Or, for example, intubation, sedation, is it like done more often for those patients or not? So this is the main focus, to understand the variability in the management for those patients.
Okay, anyone else? Last question.
Thank you for the presentation. The question would be, how long are you planning this questionnaire to be? When they are filling out the busy doctors, will it be 15 minutes, 30 minutes, an hour?
Good question. We haven't decided that, but I think we should make it as short as possible, because and I'm gonna also make it as simple as possible, so the doctors don't skip it. I know, like, they won't have enough time to fill a very long survey, and we're gonna make it, we're gonna build like a very good quality answers, so they just gonna choose which one they prefer. So we're gonna also avoid full text or freestyle answers or questions.
Thank you.